Hello, my name is Jennifer Lightdale, and I am a gastroenterologist. And I am going to give a talk on differentiating gastroesophageal reflux from gastroesophageal reflux disease in infants, or GERD versus GERD. And I'm calling it to D or not to D, and we'll see if my literary prop works for us. So I have no disclosures related to this talk and will not be discussing any unapproved or investigative use of products, devices, or drugs. My goal in the talk is really to clarify terms related to reflux disease in children, as I mentioned, GER versus GERD, to talk about how you consider options for testing and treating reflux disorders in infants. I'm going to review guidelines for appropriately managing children with reflux disease, and then I'll discuss risks associated with use of acid-suppressing medications and other drugs, but particularly focused on acid-suppressing medications such as PPIs and what we now are thinking about those. So in full disclosure, it's really not a direct line between Shakespeare's Hamlet and current concepts around infant reflux disorders. But, I try to have some little hints in my own head as to how to think about these things, and I find myself with this literary prop, to D or not to D. But I also think there's a myth around reflux. It's almost a story, and it was really a historical story in the 1980s and earlier. Nobody thought infants were refluxing. I mean, that seemed incredible. Reflux was like a stress thing that only grown-ups had when they were at work. But I think once we had endoscopy and pH testing, it was pretty clear that infants make hydrochloric acid, very strong hydrochloric acid, just like everyone, just like adults. And they are experiencing reflux. And it turns out they have even more events of reflux than adults do. And they are also at risk for developing erosive esophagitis, just like adults. And really by the 90s, we said, okay, infants reflux, and maybe that's why they're crying. So there was this whole era of, we now had medicines for reflux, and we were sort of treating infants crying for presumed GERD. And this led, of course, to this crazy rise in use of medications. In particular, in the 2000s, you really saw this 750% increase in the use of PPIs in infants, which is really incredible, and definitely was a business story. So this is a story in the Wall Street Journal from 2008 saying, babies crying? Maybe it's acid reflux disease. So, what's the backstory or the real story? It, of course, starts with the fact that infants cry. That's one of their jobs, is to cry. And unfortunately, one of the jobs of being a parent is to be exhausted and to, tend to this infant who's crying all the time. And really, parents are exhausted and they want anything at all that will help everybody in the family sleep, starting with the baby and allowing them to sleep. But unfortunately, there's no, drug, certainly nothing that is a therapeutic agent that disrupts physiologic function in the world that will come without some cost or risk. And I think it's really only in the last 5 or so years that we're really focused on the costs and risks that come with acid suppression. So I'll talk more about that. But, if you're going after suppressing acid to help everybody sleep, you may have to, pay the price of that. And really the risks of these PPIs are just starting to be elucidated. All right, so trying again my Shakespeare and sort of rethinking the tragedy of Hamlet. Act 2, is it to D or not to D? Should you suffer or should you take up armies? Should you use medications against all that acid that's in your stomach, all that sea of troubles? And it's really a, confumation, but really what's driving you is to sleep, perchance to dream. That's the rub. You all you want to do is sleep, and maybe this will help you. So that's how we got to so much PPI being used. But really, if you take a good look, there's just a preponderance of evidence that treating infants for GERD with PPI will not do anything to reduce their crying and irritability. And really, there's a whole set of stories and studies that were done really early on. I mean, we went into this knowing you cannot decrease their acid and find that it reduces crying and irritability. And also, there's a lot of issues with trying to study this. It turns out parents really differ in their own tolerance for a baby crying. And so a lot of variance in parental perception of excessive crying or sleep disturbance. So these are actually difficult studies really to pin down, but it's not clear at all that they help. What is clear is if you call it GERD, then parents want something to treat that. If you say the infant has a disease, then they want a medication. So it's really important not to use the term GERD and to say it is disease, unless it really is disease. You know, if it's not disease, don't call it that, because then parents will just want medication. So if it's not disease, what is it? So it turns out, you know, it's really, really important to recognize that even in adults, gastroesophageal reflux, which is basically gastric contents that pass up into the esophagus and may or may not make it all the way to the mouth, which is regurgitation, or out of the mouth, which is vomiting. It's actually normal physiology. That's a normal physiologic process. You're designed that way to have stuff go up and down, and it happens several times a day in healthy infants, children, and adults. And really why it's happening is probably to make you more comfortable. It lets things go up and down. You don't get, gas or have stuff that can't move. So it gets a chance to go up and down. And it really depends on the lower esophageal sphincter, which I'll show you more about, but how that actually works. And also how much your esophagus can handle before it's coming all the way up into your mouth. And it's really about transient relaxation of the lower esophageal sphincter, which is actually necessary. You need to have that transient lower esophageal sphincter relaxation, or you get very uncomfortable. So we need that to happen. And people, when they imagine the lower esophageal sphincter, I think they think of a muscle. And what's important to recognize is it's really not its own muscle. It's really more about where the diaphragmatic ligaments sort of hit the esophagus. And create something called the angle of His, so how those ligaments are coming into the esophagus. And what we know in the healthy adults is that angle is about 3 centimeters of length, and it's at the level of the diaphragm. And in newborns, it's a lot smaller, so it's only about 1.5 centimeters in length, and it's above the diaphragm. So you don't really have the diaphragm helping stuff to stay in the stomach. It's really, everything's a little bit looser, a little bit weaker, and it's all above the diaphragm. So it's, stuff very easily comes up and down in infants. But in all people of all ages, most episodes of reflux will last less than 3 minutes, definitely have to do with meals. So you're eating and they happen after meals, and they cause few or no symptoms. You don't even notice it's happening. And, you know, so that's not the answer as to why it's a disease. So Shakespeare says, he hath no stomach to this fight. But GER can be associated certainly with vomiting, which is a pretty forceful expulsion of gastric contents. And I have another lecture in this, in this course on vomiting. Or it can also be associated with regurgitation, where it just kind of makes its way up to the mouth. That's actually the most visible symptom in infants. It's actually very unusual to see regurgitation in adults, but in infants, it's very, very common. We say in at least 50% of infants, it's occurring at least daily. If you're less than 3 months of age, and then it just goes away. And, you know, and you say, well, why is that? And it really has to do with just growth. So infants have this very short esophagus, about 10 centimeters in the newborn, versus an adult male is probably about 40 centimeters, adult females 35 to 40 centimeters. So your esophagus literally gets longer as you get bigger. And then also there's smaller capacity of the esophagus, both in terms of its diameter, but also smaller capacity of the stomach. The stomach's just smaller than in adults. And then the other thing going on for adults is they have gravity. So they're standing up or sitting up, and if, especially after they've eaten, and if stuff comes up, it's, you know, they're standing up, versus infants, which are it's a very short esophagus. It very quickly comes up. And of course, the infant's mostly on their back, and it's coming up, and it's in the mouth within seconds. 10 centimeters in the adults, it's not even a third of the way up their esophagus. So that's all there is to it. And, you know, that setup, that sort of shorter esophagus, smaller capacity, and a weaker lower esophageal sphincter with more transient relaxation means that infants have many more daily episodes of reflux than older children or than adults. Their reflux lasts longer. It sort of stays in the esophagus longer. And that leads to a much higher what's called reflux index than what adults have. What's important is as the infant grows, and of course they have this extraordinary period of growth in that first year of life. And they also, of course, are having neurodevelopment progress. So they do go from lying down to sitting up to standing up to walking. And as they're doing that, reflux is going away. So you see this rather extraordinary sort of as they're having more to eat, you're seeing an increase in reflux over the first couple months of life. It sort of peaks between 4 and 6 months of life. And then we say about 41% of infants are spitting up most of their feedings at 4 months of life. And then by 6 months, you're starting to see this precipitous drop in reflux, so that less than 5% of infants ages 13 to 14 months spit up most of their feeding. This is probably a very important slide for parents and for pediatricians. So what is GERD? So GERD is a hard thing to pin down, and it's almost poetic and Shakespearean in its own way, but really there was a group that got together in 2010 and involved people from all around the world trying to come up with the right way to define when GER should be thought of as GERD. And they decided that it's when reflux of gastric contents causes either troublesome symptoms or complications. And it was really that word troublesome that they wound up focusing on. And they said symptoms due to GER are troublesome when they have an adverse effect on the well-being of the pediatric patient. So this was really, for me, a confumation, as Shakespeare would say, where you really have to say, okay, so GER is not physiologic, it's now pathologic when symptoms become troublesome. But troublesome for who? Is it troublesome for the parent or for our infant, who of course can't really tell us it's troublesome for them? So it's the parent perception of that. And what you really need to focus on is, well, how is it troublesome? And that actually is probably the most important thing to get at, because how it's troublesome is how you start to get an accurate diagnosis of what's going on. So the Wall Street Journal really sort of noticed this and settled in on this, and they said, look, this is confusing terminology. So everybody has reflux, and it usually doesn't hurt, but they did pick out the most important thing. They said, well, GER becomes more serious GERD if the infant won't eat. So the infant's job is to grow. That's actually how we get past the GER. So if they won't eat and they stop gaining weight, they vomit, maybe they vomit blood, that's less likely, and they're extremely irritable, that's when you say it's troublesome. And certainly that would be one definition of troublesome. So more recently, those guidelines have been updated, and these came out in 2014. In 2018. Basically, this was an update on the joint recommendations from the North American Society of Pediatric GI Hepatology and Nutrition and the European Society of Pediatric GI Hepatology and Nutrition, or NASPGHAN and ESPGHAN. And I think it was important that this is a worldwide thing, because it turns out reflux is not just something Americans have. And they came up with a number of troublesome symptoms and or complications of reflux. And again, the most important one is that infant is either vomiting a lot or they just have poor weight gain. They're just not gaining weight. That's probably the biggest issue. Certainly, if you're older and you can say, I have heartburn, like adults, that's considered a troublesome symptom. If you have known esophagitis, that's a troublesome symptom. But then there are all these others that are extra intestinal. So maybe you just won't eat. Maybe you have arching or seizure-like movements. You stop breathing. You're having issues with asthma or pneumonias or upper airway symptoms. All of those could be symptoms or complications of reflux. What we know is enough acid that won't clear out of the esophagus in the right people can cause esophagitis, where you really lose the vascular pattern that's normal in the esophagus. So you can't see it, you have this bad rash, and really you have erosions going on, which would be esophagitis. Having said that, the diagnostic approach to reflux in infants really has to be triggered by concerns. And then what you need to do is take a history and a physical exam, and do a physical exam. And you're trying to decide if you're worried about anything other than just acid going up and down, or food going up and down, because it might not be acid, it might be food. There you have to recognize that even better than suppressing acid are lifestyle changes, and we'll talk about what those are for an infant. Yes, you can potentially treat with acid suppression, and so there's some empirical medical therapies that you can try in the right timing, and when you really have the right history and physical exam that suggests you should give that a try. And you can examine and try to get to this with diagnostic testing. But importantly, there's really no one test that is the definition of reflux. There is no test you can do that says this is the definition of reflux. What's also clearly important is not to really rely on the historian. Babies are just terrible historians. So, they can be very sleepy, won't eat anything, sleep great, but have terrible erosive esophagitis, or they can be screaming their heads off and have no signs of esophagitis. So really the role is to make sure you're not missing another diagnosis, and then to decide if it is acid that's the problem, or whether there are lifestyle changes you can make that can help the infant. Differentiating GER from GERD, really the number one troublesome symptom has to be inadequate weight gain. So you see a baby not growing, that should prompt concern for GERD. And then you're moving into, well, what else do I need to think about? And that's other worrisome disorders that might present with vomiting, or other signs that you're dealing with complications of GERD. So the list of what else it can be is very long, and it certainly can involve GI disorders, and I've got a whole host of them here, but I want you to recognize that a lot of them, especially if the story is vomiting, may involve obstruction or some change to the anatomy, or in the case of Hirschsprung's disease, maybe the colon isn't working and so things are backing up. But really, most of these are going to be anatomical variations that can mean that food is not passing down. And if that's the case, then that infant is going to be refluxing or vomiting a lot. And then there's all these other GI disorders, and really most of them are not going to be issues that you have in infants, so you don't really have to worry about it, with the exception of milk protein allergy, which we'll talk about. And then there are all these non-GI symptoms. And for me, I will tell you that this is really important to me as a pediatric gastroenterologist, that the pediatrician has done the job of thinking about non-GI issues. So obviously sepsis, UTI, otitis media, those again should be things to be thought about in your office. Neurologically, don't miss if the child looks like they have a large head or might have something going on that sounds like you need to be thinking neurologically. Always check the newborn screen. Certainly one of the first signs of a metabolic disorder will be vomiting and what looks like reflux. And then certainly there can be cardiac issues or renal issues or toxic issues, including lead. And then there certainly can be sort of psychiatric or social psychiatric issues. So something to think about. What I always remember is I once had an infant. I had never seen cri du chat. And I walked into the room and the mother was there saying, well, my baby has terrible reflux. And I was listening and hearing and looking at a baby who I was very worried about. And it turned out it was cri du chat. So, that isn't to send ideally for reflux. That's really to recognize that lots of things cause the babies to vomit and have reflux, but to be looking at that whole baby gets so important. All right, so what tests can you do for reflux disorder? So first off, there are many options. And again, no one test can diagnose reflux. And that is officially another rub. So you really have to have a clinical question. If you're worrying about cri du chat, get the geneticists involved. But if you're worrying about the head, you might want to think about head imaging, or, like I said, check the newborn screen. And then, yeah, sure, there are actual tests to think about reflux from a GI perspective. And these can document presence of GERD, they can detect complications, they can be used to establish causal relationships between GERD and symptoms, evaluate therapy. Mostly they're to exclude other conditions. So most of what you're doing is trying to say, well, am I missing something? So there, I think the number one test for all clinicians, general pediatric clinicians, primary care clinicians, as well as specialty clinicians, should recognize that infants, when they really seem to be refluxing a lot, the test that may help you to say, gee, could I have something like malrotation, which is more common than people often recognize. Most people never know they have malrotation. To get to that, you need an upper GI. And the upper GI will help you also rule out a whole bunch of other things like pyloric stenosis, or, just will think about, is the anatomy the way I think it is? And so it's really quite useful for detecting relatively common anatomic abnormalities. And yes, it can show you reflux. The truth is, it's really not a test of function. So if the radiologist gives the baby the contrast and then turns the baby on their side, they will officially reflux. But it will, it will tell you, yes, you've got malrotation, or hopefully, no, you don't. And I'll just say, hint, hint, that is one of the MOC questions. So just to know, upper GI really should be one of the tests you're very comfortable ordering. So, here's pyloric stenosis, really showing a hypertrophied pylorus, and so you have a stenosis going on there. And then this is malrotation, where you don't have ligament of Treitz in the right place, which should be over here, and you have this corkscrew appearance. What about endoscopy? So sure, endoscopy can be used to evaluate for a variety of conditions, but is absolutely not required for a diagnosis of GERD. You never see GERD happening on endoscopy. You just may see signs of esophagitis. You may see other reasons for esophagitis, like allergic esophagitis or Candida or CMV. But it's certainly a big test. This guy's awake, but most 100% of infants, we're going to put them to sleep with an anesthesiologist. So it takes a few minutes to do the endoscopy, but there's a lot of risk involved in it. And again, it's not how you diagnose GERD. So most of us would not move to endoscopy as an early test. And this is just showing, sometimes you can't see it through the scope, but under the microscope, you are seeing some of the swelling of the esophagus, what they call the basal layer of the esophagus is swollen, and you have these, basically the papilla get deepening, and you might see it that way. And then if you see tons of eosinophils, then you're into this world of allergic esophagitis, so eosinophilic esophagitis. What about pH probes? So I think this was like a big fad in the early 2000s, and certainly, you can detect episodes of acid reflux. You may say, oh, I saw the acid reflux come up and now the baby's crying. You can say, well, there's acid in the esophagus and it took 20 minutes for it to get out of the esophagus. So that would be saying there's something wrong with the clearance. But it's not the most helpful test in the sense that infants eat all the time, so the acid's often buffered. They're not necessarily refluxing acid contents. And it really doesn't tell you anything about complications. The temporal relationships are often quite difficult to discern. And so it's not a great test. What we have moved to instead a little bit is intraluminal impedance. This can pick up not just acid reflux, but also non-acid reflux. It's looking for changes in the pressures of the esophagus. And I think this is a useful test because it's not really looking at acid. It looks at acid and non-acid reflux, and that by linking the pH probe to the impedance probes. But we don't know a lot about what are normal values in pediatric age groups. And it's a very time-intensive test in many ways, also very invasive. You have to leave the impedance monitor in for a long time. So it's something we try to do just in very select situations. This is a picture of the catheters with the impedance probes and the pH probes. And again, not something one wants to do in every infant with reflux, because it's, as I said, about 40% of infants at age 4 months of age. So, this is just a picture of what we can see with non-acid reflux. So impedance, has its place. But most of the time you want to do it based on, is the infant growing or not growing? And do I think the symptoms really push me to saying, well, I think there could be an acid component to why this infant is not thriving. Most of the time in the infant with recurrent regurgitation, so lots of stuff coming out of the mouth, but the baby's otherwise doing great, like growing along that growth curve at 30 to 50th percentile. Most of the time it's parental education, reassurance, anticipatory guidance. This is going to get worse from 4 to 6 months until it gets better, starting at 6 months, but it's going to get better. And you really don't have to do any other intervention except if they're really pushing you, that's what I mentioned, or you're worried enough or something that you're saying, especially if there's a decrease on the growth curve, you're like, I should do something. That might be an upper GI. But most of these infants, if they're growing perfectly, you do not need to do anything except educate them that this is normal and is going to get better. And it's really only when those infants, if they continue to have symptoms at 12 to 18 months, or the symptoms are worsening, that you need to talk about referral. What about crying? Well, it turns out infants cry. And again, they cry the most between 1 and 3 months of age. They cry a little bit less between 4 and 6 months of age, but they cry. And this is, looking at that. So that's not going to be your useful measure. What we know is that you can take this conservative approach, and there's an evidence basis for this. And this was an important study that looked at a lot of infants using a couple different measures. And what they found is it was all about lifestyle change. And that was less feedings more often, positioning, holding the baby upright, and avoiding tobacco soap. Avoiding tobacco smoke. Like those were really the lifestyle changes that they went for, and that made an enormous difference for these infants. And actually, in 25% of infants, actually, the GERD completely resolved. Some of that, of course, could have been depending on their age. Accurate, I think, what you want to be doing is getting across that there are these fundamental truths, right? So you have symptoms of regurgitation, colic, irritability, vomiting. That's all normal. And then what you also want to know in the back of your head is, well, some of those can also be things that you see with food allergy. So I'm going to talk a little bit about food allergy. I think the guidelines give a very nice algorithm. And what you want to see is the first thing you do when you're suspicious of GERD is to look for alarm signs. So when I talk about alarm signs, I'm of course talking about everything we were just saying. You might have one of those neurological conditions or something that you do need to do something about, including malrotation. But if you're not dealing with alarm signs, you need to start wondering, what is the baby feeding and how are they feeding? And here they really talk about avoiding overfeeding. So perhaps the infant isn't ready for 4 ounces. Let's bring it down to 3 ounces and give feeds more often. Maybe you should thicken feeds. They'll talk about that. So, in terms of thickening of formula, that is one thing you can do. You can do positioning, so you can do supine positioning for sleeping. And then you can also do a 2 to 4 week trial of an extensively protein hydrolysate formula, and that is because of this overlap with milk protein allergy. So thickening with rice, when we talk about thickening, we really want it thick. We really want to be able to tilt the plate and it doesn't move. And what we know is if you thicken formula a lot, you will have less vomiting, more sleeping, and a little bit less crying. But you have to beware that the caloric density goes up extraordinarily for the formula. And so what that means is you wind up with this very thick formula that is frankly designed to give more calories to the infant, so they will become plump more quickly, and that's probably not healthy. And then the other thing it does is it actually leaves the formula sitting in the stomach longer, which decreases their gastric emptying. So that can, over time, also contribute to reflux. There are these pre-thickened formulas which change viscosity without adding caloric density, and to some extent those might be a good way to go. But what you want to know is that it, if you do that, you really want to be doing this without giving the baby an acid suppressing medication, because these pre-thickened formulas actually require acid in the stomach in order to work. So really, pre-thickened formulas are an option, but again, you're really working with lifestyle change here, not with acid suppression. And lots of data showing that it helps with regurgitation and vomiting. Another thing you can do is focus on positioning. So we know a lot about positioning. First off, people always say, well, I put the baby in the car seat to eat. Well, the truth is, it depends. If the knees are up into the chest, it may actually be crunching the stomach, and you may find that you're refluxing a fair amount. If your baby is supine, for sure, they're going to be refluxing a lot. That really has to do with where the esophagus hits the stomach. And grandma, of course, knew, but it is true, if the baby is prone, the stomach is dependent, falls away from the esophagus, and you will have probably the least amount of reflux. Notice the year on this study is 1981. And, we have certainly more recently, so this is 2007 data actually using a lot of impedance. What you can see is that positioning does matter. So, all of that does hold true, but also right side versus left side, it turns out really can make a difference. So if you're lying on your side, on your right side, it seems to easily fall into the esophagus, versus if you're on your left side, where it sort of falls away from the esophagus. So certainly you can be, to decrease reflux, prone positioning or side positioning, left side positioning can help. The problem really is around the trade-off. So the trade-off here is the SIDS mortality, and it's pretty dramatic that if, depending on how you're lying. Yes, if you're prone, you're going to have this very low reflux index and less chance of refluxing. The issue is the SIDS mortality goes up dramatically if you're in the prone side. So we don't recommend prone. You can do left side, but not, very carefully monitored. And really, you want to be on your back to sleep, and you want to recognize that positioning matters. So really what you want to do post-feed is be holding the baby up, and that can make a big difference. And then what about the extensively hydrolyzed formula? Well, it turns out there's this big overlap with symptoms between GERD and milk protein allergy. And so you want to recognize it, you want to know it, and you should have a suspicion for milk protein allergy, which is usually non-IgE mediated. So, you can't do IgE testing to define it. You just have to recognize that it's common. And you have to know that it may be being triggered or even exacerbated by acid reflux. So there are lots of studies out there that have shown that extensively hydrolyzed formulas can reduce symptoms in symptomatic infants, including around crying. That works much better than drugs, but also in terms of the vomiting and the reflux. And so the guidelines say to do 2 to 4 weeks of a protein hydrolysate or amino acid-based formula. And then in breastfed infants, you should eliminate cow's milk from mom's diet. And in full disclosure, I do milk and eggs and often soy as well from mom's diet. So I want 2 to 4 weeks of that dietary change in most infants with reflux because it is so common, and that often is much more effective than actually putting them on medications. All right, so what about medications? Well, the guidelines say if you have not had improvement with the formula, or if it's improved but there's still a concern for reflux, that's when you should try 4 to 8 weeks of pharmacotherapy. And the goals of the pharmacotherapy are really, to control symptoms, but to promote healing, prevent complications, and ideally improve quality of life. Your goals always are to avoid adverse effects of treatment. So anything we do, you need to say, well, that's great that it does that, but is it actually also causing a side effect? So, when we say acid suppression, what we're really doing is trying to suppress the activity of the gastric parietal cell. And acid is made in the parietal cells, and it's stimulated to be made in a couple of ways. One is with a histamine 2 receptor, which basically works topically on the upper side of the apical side of the cell. And then what you're seeing is down being fed by the bloodstream is where you'll have a couple of other important receptors. Importantly, the proton pump inhibitor can get into the cell this way and can block the proton pump from basically producing the hydrochloric acid. So both H2 blockers and PPIs can produce relief of symptoms and mucosal healing, and both are superior to buffering agents, alginate, sucralfate. PPIs are without a doubt, hands down, superior to H2 blockers at relieving symptoms and at healing esophagitis. So they are much more efficacious drugs. They need to be given in a way that lets them get absorbed into the bloodstream and back around to the back of the cells, if you will, in order to be working for you. So we do talk about optimal timing of PPI dose. It's ideally in adults or older kids, it's half an hour before breakfast. And if you're giving it in the evening as well, half an hour before an evening meal. They say, well, why doesn't it seem to work in infants? And some of it is that infants don't eat 3 meals a day. They're sort of eating all the time. Some infants eat every 2 hours. Some infants eat every 3 hours. Some infants eat every 4 hours. So this was a very nicely done study in 2012, really showing, well, the medications are working for you. They're certainly suppressing the acid, but really what's determining whether or not you have reflux is how long you're going between feeds and when you're eating. So it's every 2 hours, 3 hours, 4 hours. That's actually what's determining how much reflux you have. And the other thing the study looked at is how fast the feeds were being given. Were they gavage fed, or was it taking by bottle? In children, like with adults, omeprazole and any of the PPIs are incredibly effective at healing erosive esophagitis. And that does seem to be a dose experience. So the higher the dose is, the better they are at healing esophagitis. And again, this was shown with lansoprazole, which is another PPI. And what you're seeing here is this was, yes, very good at basically dealing with esophagitis, just didn't help with the crying or the regurgitation. So, and again, these are more studies showing, yes, omeprazole has no effect on crying compared to placebo. So, if you're trying to heal esophagitis, that's what they do. They don't really help you with the crying. And then they come with a whole bunch of potential risks. So it turns out gastric acid, hydrochloric acid in your stomach is not there just to cause reflux and pain. It also emulsifies a number of hard minerals and vitamins, including iron, calcium, magnesium. So if we don't have it there to soften those, they may not be absorbed as well. The acid bath is one way of controlling what organisms can make their way into the GI tract. So if you don't have that acid bath there, you may increase your potential for infections, particularly around C. diff and pneumonia and small bowel bacterial overgrowth. And then we do worry about other complications. And again, some of this is we really think of the stomach as the number one place for a proton pump, but it turns out the kidneys may have some binding sites. And then it may be that changing the microbiome is highly associated with a number of conditions like neck, and then also cardiac disease. Getting at this has been tricky, but there are some, because they're all association studies, and they're not necessarily, most of them are not about the drug themselves. Most of them are about what happens when you suppress acid. But what we do know is if you really look across, especially critical care populations, you see some real themes in terms of which outcome you'll see more of. And again, this is mostly in critical care situations. So it is hard to extrapolate this to somebody's otherwise healthy baby who's at home in the ambulatory setting. But what we do know is, again, no drug comes without some risk. And the risk here is that you are suppressing acid, and maybe that is physiologically not normal. And so you're going to pay a price for it. People say, well, why do you get more infections? Again, it's this decreased acid barrier, the altered microbiome, maybe the immune response is attenuated, the bacteria themselves may be able to take root. And again, maybe antibiotics don't work the same. So these are all questions that have been in place. Lots of studies have looked at C. diff, and what I want to point out, this was a nice one that's pointing out, this is really about acid suppression. So if you look, you're finding the same results for the PPI as well as the H2 blockers like ranitidine, or ranitidine's now off the market, so famotidine, but I think this was ranitidine at the time. What you're seeing is it's the same acid suppressive effect, you just want to be aware. This is really about acid suppression as the driver, less than the way it's being suppressed. And again, this was a ranitidine study in 2012 saying, look, that too can be associated with infections, necrotizing enterocolitis, and fatal outcomes in newborns. So, where are we right now with PPIs? They're really effective at healing esophagitis. If there's irritation, inflammation in the esophagus, it's going to be effective at healing that. But it has nothing to do with the infant discomfort. This really shouldn't be seen as infant discomfort. It should be seen, if the infant is showing you, they start to eat, they stop, they look like they're in pain, that's very different from the baby who's just crying all the time. So, try to get a real story that makes you feel confident that this will help. And then use them conservatively. Don't totally not use them. In fact, I'm finding it difficult now. Infants are not getting the medication they deserve. The family's giving a clear story for GERD, but you want to use them conservatively, certainly not just for the infant that's crying a lot. And to recognize and to counsel the family about, why you're treating and what you're thinking about. What about prokinetic agents? So a lot of people have said, well, we can't use PPI. I want to go back to using, Reglan or metoclopramide or cisapride, which is now withdrawn. So the truth is there is no prokinetic agent that has ever been found to be safe. In fact, metoclopramide has this terrible side effect profile. Say 30% of patients experience adverse side effects. And of course, most of them are either withdrawn or are really not available in the United States. And that's because they don't really work. and they're unsafe. And again, these are side effect profiles of prokinetic agents to be aware of, and they are very common. So we basically say, yeah, don't use prokinetic agents. That's not a good answer either. Really focus on those lifestyle changes. And if you should and need to, try the acid suppressing medications in an empiric way to see whether that helps. All right, so take-home messages are, it's important here to clarify whether a pediatric patient has physiologic GER or pathologic GERD, to try lifestyle changes for both, mostly positioning, mostly dietary changes. Dietary changes change the frequency and amount that is being fed, but also to change to hypoallergenic formula, since there's so much overlap with milk protein allergy, or in a breastfeeding mother, to exclude the allergenic foods from her diet, starting with milk and considering eggs and soy as well are good places to start. You can use pharmacotherapy. It's very effective at acid suppression, but you should do it prudently, only treating those infants who they really have a story that you say, I think this could be it. And then certainly in terms of testing and treating, you use the guidelines. Try to understand when you might want to do something, including that upper GI. And also those guidelines are helpful for deciding when to refer to the subspecialist. Very importantly is not to call it GERD unless it's absolutely GERD, because using that term GERD is going to influence your patients more than you realize. And then taking a careful feeding history, focusing on volume, frequency, composition, that identifies overfeeding, overconcentrating, but also really thinks about milk protein allergy from an family perspective and atopic perspective. That's probably going to be where you really can make the most difference for these infants, not necessarily with medications. So it turns out there's a lot of sayings that we can owe to, we owe to Shakespeare. He had wonderful terms for everything. And I don't know if he'd appreciate being linked to infant reflux disorders, but I have done that. So I give him evermore thanks.